Imagine for just a moment that you are a transplant surgeon.
Okay.
And you have this young patient
Right.
with severe cystic fibrosis.
Right. Their lungs are completely failing.
Exactly. So you perform this masterful, life-saving bilateral lung transplant. I mean, you literally give them a completely new lease on life.
They can breathe again?
Yeah. They can run. They survive for another, 10, maybe 15 years.
Which is incredible.
It is. But then, tragically, that exact same patient develops this incredibly aggressive, fatal colorectal cancer.
Wow.
And when you look at the epidemiological data in our source material, you realize that by giving them that lung transplant and placing them on those heavy immunosuppressants, you inadvertently increase their baseline risk of developing colorectal cancer by 2,000%.
2,000%. I mean, it's a profound paradox of modern medicine.
It really is. Welcome to this deep dive into our source material. Today, we are mapping the terrifying, complex, and highly tested world of genetic colorectal cancer syndromes.
Because as our interventions keep patients alive longer, we're unmasking entirely new, genetically hardwired dangers that were previously just hidden.
Yeah.
And navigating that landscape requires an absolute fundamental mastery of the molecular biology.
Exactly. And that brings us directly to you, our listener. We know exactly who is tuning in today.
You're likely a clinician deep into your preparation for high-level medical board exams like the FRCS.
Or you're a molecular biology researcher working at the PhD level. You aren't here for a basic overview.
No, not at all.
Your mission with this deep dive is to completely master the pathophysiology, the genetic signaling pathways, and crucially, the strict statistical criteria of these predispositions.
Because you need to know how to differentiate these syndromes in a clinical vignette,
Right.
especially when the board examiners are actively trying to trap you.
Right.
Because out there in your clinic, missing one of these really nuanced genetic flags doesn't just mean a misdiagnosis.
It means a missed opportunity for prophylactic surgery.
Exactly. It means a cancer that could have been prevented. I mean, it alters the entire trajectory of a family tree.
So today we are taking our source material and we're going granular. We're going to explore the high-penetrance and the moderate-penetrance genetic syndromes.
Breaking down the exact gene mutations.
Right, the clinical diagnostic criteria and the hard statistical risks. But before we dive into the actual molecular cascades, let's kind of set the clinical stage.
Good idea.
Epidemiologically speaking, what is the baseline reality of colorectal cancer right now?
Well, the statistics are, frankly, quite sobering, and they are shifting rapidly.
How so?
So in the United States, colorectal cancer, or CRC, is currently the third most commonly diagnosed cancer.
Okay.
It's also the third leading cause of cancer-related deaths overall. But if you are studying oncology trends, there is one demographic shift that should just immediately grab your attention.
The younger demographic?
Yes. CRC is now the leading cause of cancer deaths in men aged 50 or younger.
Wow.
Let me repeat that because it's huge. The leading cause.
And for women?
For women in that exact same under 50 age group, it is the second leading cause of cancer deaths, sitting right behind breast cancer.
See, that under 50 statistic is exactly why the boards test this so heavily. Because when a 35-year-old or, a 40-year-old presents with a colon tumor, you are operating in a completely different paradigm than if a 75-year-old presented with the exact same histology.
Completely different. You have to assume a genetic etiology until proven otherwise.
Right. So let's break down the origins of CRC into a sort of conceptual pie chart based on the text.
Okay, so the largest slice of that pie is about 65%.
And those are the sporadic cases, right?
Exactly. These are your sporadic cancers. They're driven by an accumulation of environmental factors over time, so aging, diet, lifestyle, just random somatic mutations.
So there's no inherited germline familial link there?
No, none. Now, the next slice represents about 25% of cases, and these are categorized as familial.
Right, and familial simply means there is a family history, specifically having a first-degree relative with CRC or advanced adenomatous polyps.
Yeah, and the data shows that simply having that first-degree relative immediately doubles your risk compared to the baseline population.
But just to be clear for the listeners, we aren't talking about a single identified gene in those familial cases, are we?
No, we're not. It's just a shared genetic and environmental susceptibility.
Okay, so what's the rest of the pie?
The final slice which is roughly 10% of all CRC cases, is the actual focus of our deep dive today.
The hereditary syndromes.
Yes. These are the true hereditary or genetic CRC syndromes, cases driven by highly specific, identifiable, inherited germline mutations.
10% might sound like a small slice to some people, but clinically, the weight of that 10% is massive.
Oh, absolutely.
Because these hereditary syndromes drive multiple primary malignancies across various organ systems. They often strike decades earlier than sporadic cancers.
And they can be wildly aggressive.
So, if I am a clinician taking a history in my office, what are the strict clinical red flags? Like, when must my radar start pinging to investigate a hereditary cause?
Well, according to the sources, there are 4 major criteria you really need to commit to memory.
Okay, hit me.
First, a significant family history. So that's having 2 or more first-degree relatives, parents, siblings, or children of the proband with CRC or premalignant colon polyps.
Right. And the second?
Second is a family history of other cancers that are known to run in these hereditary CRC networks. And the massive blaring siren here is endometrial cancer.
Endometrial cancer.
Yes. If you see early CRC and endometrial cancer in a family tree, your brain must immediately jump to hereditary syndromes.
Endometrial cancer is the key. I mean, it is the great differentiator on board exams.
It really is.
So what are the other 2 flags?
The third is the onset of CRC at an unusually early age. Again, tying back to that under 50 mortality surge we just talked about.
So if the patient is under 50, you screen for genetics.
Exactly. And fourth, finding multiple primary cancers in a single individual.
So like a patient who had a primary CRC resected at age 40 and then, I don't know, presents with a completely new primary gastric cancer at 48.
Precisely. If you see any one of those 4 factors, the investigation for a genetic cause absolutely must be initiated.
Okay, so that perfectly sets our clinical boundaries. Now let's get into the actual molecular biology.
Let's do it.
If we are starting with that 10% hereditary slice, we have to start with the absolute heavyweight.
Lynch syndrome.
Exactly. The most common high-penetrance genetic syndrome of them all. Lynch syndrome, which historically went by the name hereditary non-polyposis colorectal cancer, or HNPCC.
Right. And Lynch syndrome follows an autosomal dominant inheritance pattern.
Meaning inheriting just one mutated allele from either parent is sufficient to confer the high-risk phenotype?
Yes. And the entire molecular pathophysiology of Lynch syndrome centers on a catastrophic failure in the mismatch repair pathway, or the MMR genes.
Let's visualize this mechanism for the listeners. I always like to think of human DNA replication as this massive, impossibly fast printing press.
That's a great analogy.
Every time a cell divides, it has to churn out billions of letters of genetic code. And because it's moving so incredibly fast, occasionally the machinery just makes a typo.
Right, it prints a G instead of an A.
Or it inserts an extra letter, creating a tiny loop in the strand. So the MMR genes are the crucial microscopic proofreaders of the cell.
They physically follow behind the printing press.
Yeah, they scan the fresh DNA, they spot the typo, they cut that section out, and they call in the repair enzymes to fix it.
But in Lynch syndrome, one of those proofreaders is fundamentally missing from birth.
Exactly. And for your exams, you cannot just know the concept, right? You need to know the specific proofreaders in descending order of prevalence.
Yes, you do. The most commonly mutated MMR gene in Lynch syndrome is PMS2.
PMS2.
Right, and that is followed by MLH1, then MSH6, and finally MSH2.
So if any one of those 4 genes is mutated in the germline, the proofreading complex cannot assemble correctly.
And mutations begin to accumulate at a terrifying rate, particularly in regions of repetitive DNA called microsatellites.
Which leads to microsatellite instability, or MSI.
Exactly.
Now here is where it gets incredibly complex at the molecular level, and our source material highlights this as a favorite topic for PhD researchers.
The EPCM deletion.
Yes. It isn't always a direct mutation to those 4 MMR genes. There is a fascinating epigenetic backdoor that can cause Lynch syndrome.
It's incredible biology.
The literature details how a deletion in a completely different neighboring gene, the epithelial cellular adhesion molecule, or EPCM gene, can actually cause a perfect phenocopy of Lynch.
Yes.
So how does a deletion in a cellular adhesion gene break a DNA proofreader?
Well, this is a beautiful example of how genomic architecture matters just as much as the DNA sequence itself.
Okay, break it down.
So the EPCM gene sits directly upstream, physically right next to the MSH2 gene on the chromosome. Normally, when the cell transcribes the EPCM gene, it reaches a stop signal at the end of the gene, the machinery detaches, and all is well.
But in this specific mutation, the tail end of the EPCM gene, including that crucial termination signal, is deleted.
Exactly. So the transcription machinery just keeps going.
It just plows right through.
Precisely. The RNA polymerase reads right through the end of the EPCM gene and plows directly into the promoter region of the neighboring MSH2 gene.
Oh, wow.
And this abnormal read-through transcription acts as a signal to the cell's epigenetic machinery. It essentially tricks the cell into thinking, oh, we need to shut this area down.
Because it looks like an error.
Right. So the cell responds by aggressively methylating the MSH2 promoter. This hypermethylation physically tightens the DNA around the histones, completely silencing the MSH2 gene.
So wait, the patient has a perfectly healthy, unmutated MSH2 gene.
Yes, but it has been permanently switched off by the broken gene next door.
That is wild.
It results in a complete loss of MSH2 protein expression in any tissue that expresses EPSAM.
That is such an incredible molecular quirk. The gene is there, but the lights are just turned out.
Exactly.
So whether it's a direct mutation in MLH1 or PMS2 or EPC silencing MSH2, the end result is the same. The proofreaders are gone.
Right.
And this leads us to the diagnostic testing algorithm. If I am an FRCS candidate looking at a board question, this algorithm is practically guaranteed to show up.
Oh, without a doubt.
So let's walk through a clinical vignette. You have a 45-year-old patient who presents with a right-sided colon mass.
Okay.
You resect it, pathology comes back, and you order immunohistochemistry or IHC testing on the tumor tissue to look for the 4-MMR protein.
It's a standard protocol.
Right, and the IHC report says loss of nuclear expression for MLH1 and PMS2, MSH2 and MSH6 are intact.
Okay, so the MLH1 proofreader is missing.
My gut instinct as a surgeon is to immediately diagnose Lynch syndrome and send the patient for germline genetic testing.
But you can't.
Right. The algorithm demands that before I do that, I must test the tumor for a specific mutation called BRAF-V600E. So wait, let me get this straight. If an IHC test shows a loss of MLH1, why do we test for BIF?
It's the classic board trap.
And more importantly, why does finding a positive BRAF-V600E mutation mean the cancer is sporadic and not Lynch syndrome? I mean, if the proofreader is gone, shouldn't it be Lynch?
They are testing your understanding of somatic versus germline events.
Yeah.
You have to ask why the MLH1 protein is missing.
Okay.
In Lynch syndrome, MLH1 is missing because the patient inherited a broken copy of the gene from birth, a germline event.
Right.
But in roughly 15% of all sporadic non-hereditary colon cancers, the tumor actually manages to shut down the MLH1 gene all on its own.
Really?
Through acquired localized promoter hypermethylation. It's a localized somatic event confined entirely to the tumor cells.
Okay, so a sporadic tumor can effectively teach itself how to turn off the proofreader.
Exactly. And we know that the BRAF V600E mutation is a major molecular driver of this specific sporadic methylation pathway.
Ah, I see.
Crucially, germline Lynch syndrome tumors almost never possess a BRAF V600E mutation.
So if you test the tumor and find the BRAF mutation is positive, it acts as a molecular signature.
Yes. It tells you this loss of MLH1 is a localized sporadic event driven by the BRAF pathway. This patient does not have inherited Lynch syndrome.
And you can halt the hereditary evaluation right there, saving the patient and their family immense anxiety, not to mention unnecessary genetic testing.
Precisely.
But what if the BRAF test is negative?
If BRAF is negative, you still aren't fully in the clear for Lynch. The next step is to directly test the tumor for MLH1 promoter hypermethylation.
Okay.
If that comes back positive, it again confirms the tumor shut down MLH1 sporadically.
So when do you actually sequence for Lynch?
It is only when both BRAF is negative and the MLH1 hypermethylation is negative that you have a high clinical suspicion for true germline Lynch syndrome, and you proceed with germline genetic sequencing.
That step-by-step logic is exactly what separates a competent surgeon from a true expert. You really have to follow the molecular breadcrumbs.
You do.
So let's look at the patients who make it through that algorithm and truly have Lynch syndrome. What does their clinical phenotype look like?
It's stark.
Yeah.
And very aggressive.
What are the hard statistical risks?
Well, Lynch-associated CRCs develop much earlier than sporadic cases. They typically strike in the patient's mid-40s.
And anatomically?
Anatomically, these tumors have a strong predilection for the right side of the colon, the proximal colon.
Which makes them a lot harder to spot on a standard flexible sigmoidoscopy, right?
Exactly. They require full colonoscopies. And their behavior is relentless. They frequently present as multiple synchronous tumors.
Meaning you find two or more independent colon cancers at the exact same time.
Right. or as metachronous tumors,
Mm.
meaning a patient has a section of colon removed for cancer, and 5 years later, a completely new primary cancer develops in the remaining colon.
That's devastating. And the lifetime statistical risks are staggering. For colorectal cancer, an individual with Lynch syndrome faces up to an 80% lifetime risk.
80%.
But as we noted from the source material, this is not just a colon disease. For female patients with Lynch, there is a massive 40% lifetime risk of developing endometrial cancer.
And that ties perfectly back to our clinical red flags. That is exactly why endometrial cancer in a family tree is a blaring siren for Lynch.
But the risks extend even further, don't they?
They do. Depending on the specific gene mutated, and keep in mind that MLH1 and MSH2 mutations generally carry the highest overall penetrance and cancer risks, while MSH6 and PMS2 have slightly lower risks and later ages of onset patients are vulnerable across multiple organ systems.
Right. They face significantly elevated risks for ovarian adenocarcinoma, gastric adenocarcinoma, small bowel cancers, and pancreaticobiliary adenocarcinomas.
And the epidemiological data also specifically highlights an increased risk for upper urinary tract transitional cell cancers.
So cancers of the renal pelvis and ureters.
Exactly, which is particularly strongly associated with the MSH2 mutation. There is also an observed increased risk for prostate cancer.
Wow. And this multi-organ vulnerability is a perfect segue into the specific named subtypes of Lynch syndrome.
Because sometimes the genetic defect expresses itself outwardly beyond the internal organs.
Yeah, let's talk about Muir-Torre syndrome.
Muir-Torre syndrome is a fascinating, highly tested clinical variant. Think of it as Lynch syndrome plus a very specific dermatological phenotype.
Skin lesions.
Yes. These patients develop rare sebaceous skin neoplasms, specifically sebaceous adenomas, sebaceous carcinomas, and keratoacanthomas.
And which gene is that linked to?
While Muir-Torre has been reported with mutations in MLH1, MSH6, and PMS2, the vast majority of cases are most strongly linked to mutations in the MSH2 gene.
So if you are a clinician and a 42-year-old patient presents with right-sided colon cancer, and during your physical exam you notice multiple yellowish, waxy papules on their face, which turn out to be sebaceous adenomas, your brain needs to instantly connect those dots.
Colon cancer plus sebaceous adenomas equals Muir-Torre.
Which equals an MSH2 mutation. And then there's the other major Lynch variant, Turco syndrome type 1.
Right, Turco syndrome. This is an older historical classification that essentially describes any syndrome combining colon polyposis or cancer with primary brain tumors.
But we now split it molecularly, right?
Yes. Turco type 1 is specifically the Lynch-associated variant. Now, this is a vital distinction for your genetics knowledge. Unlike classic Lynch syndrome, which is autosomal dominant, Turco type 1 is usually an autosomal recessive trait.
Recessive.
Yes. It is typically caused by a patient inheriting biallelic mutations, so mutations in both copies of either the MLH1 or PMS2 genes.
Inheriting two broken mismatch repair genes, I mean, the proofreading system isn't just impaired, it is completely obliterated from conception.
Obliterated.
What does that clinical manifestation even look like?
It is devastating. It accounts for about 20 to 25% of all historical Turco cases. It's characterized by early onset CRC, lipomas, café au lait spots on the skin, basal cell skin cancers.
And the brain tumors.
Yes, and most lethally, aggressive brain and spinal cord tumors overwhelmingly presenting as glioblastomas.
Let's pause on that. Why glioblastomas? Why does a mismatch repair defect hit glial cells in the brain so hard?
It comes down to the rapid division of glial cells during neurodevelopment and their susceptibility to replication errors.
Okay.
When you have a biallelic MMR mutation, which is often called constitutional mismatch repair deficiency, or CMMRD, the mutation rate in rapidly dividing embryonic neuroglial cells is so catastrophically high that malignant transformation into a glioblastoma often occurs in childhood or early adolescence.
Long before the colon cancer even has time to develop.
Exactly. It is a brutal manifestation of total proofreading failure.
Well, that thoroughly covers the mismatch repair defects. Now, we need to shift our paradigm entirely.
At a completely different mechanism.
Right. We are moving away from the proofreaders that fix typos after the fact, and we are moving to the structural integrity of the cell division process itself. We are transitioning to the tumor suppressor genes.
The APC gene.
Yes. Let's explore the adenomatous polyposis coli gene, or the APC gene, and its variations.
When you hear the phrase APC gene on a word rounder in a board question, your mind should immediately go to Familial Adenomatous Polyposis, or classic FAP.
If Lynch syndrome is the invisible killer, few polyps, Sudden cancer FAP is the explosive, highly visible archetype of the polyposis syndromes.
The clinical criteria for classic FAP are visually unmistakable.
Yeah.
If you are a gastroenterologist doing a colonoscopy on an FAP patient, you are hunting for 3 or 4 subtle polyps.
No.
You are looking at hundreds, often thousands, of adenomatous polyps literally blanketing the entire mucosal surface of the colon and rectum. It looks like a carpet of tumors.
The pathophysiology here is critical to understand. The APC gene is a classic tumor suppressor gene. It acts as the primary brake pedal in the white signaling pathway.
Right.
Specifically, its job is to bind to and degrade a protein called beta-catenin.
And when the APC gene is mutated, the brake pedal is gone.
Exactly. Beta-catenin builds up in the cell, enters the nucleus, and constantly tells the cell to divide and proliferate.
And that unchecked proliferation is exactly what causes thousands of polyps to erupt.
And the brutal statistical reality that every FRCS candidate must know is this. In classic FAP, without highly aggressive surgical intervention, specifically a subtotal or total proctocolectomy, nearly 90% of affected individuals will develop colorectal cancer by age 45.
90%.
The sheer mathematical volume of precancerous lesions makes malignant transformation an absolute certainty. It's not a question of if, but when.
Exactly. But the Wnt pathway is active in many tissues, not just the colon. So FAP carries a host of severe extraintestinal risks.
Like the stomach and small bowel.
Yes, these patients almost universally develop gastric and duodenal adenomatous polyps. The duodenal polyposis is so severe and carries such a high risk for periampullary cancer that it must be tracked using a specialized scoring metric.
Right, the Spiegelman staging system.
Yeah.
Let's unpack the Spiegelman system because it's a great example of clinical precision.
It doesn't just look at one factor.
No, it stages the duodenal severity from stage 0 to stage IV by assigning points based on 4 distinct variables.
The sheer number of polyps,
Their size in millimeters.
their histological type, whether they are tubular, tubulovillous, or villous,
and the degree of dysplasia from mild to severe.
and a stage 5 Spiegelman score means a massive risk of duodenal cancer.
Yeah.
It often requires a prophylactic Whipple procedure, even if their colon has already been removed.
And beyond the GI tract, classic FAP patients are at risk for pediatric hepatoblastomas, thyroid cancer, specifically the cribriform morular variant of papillary thyroid cancer, pancreaticobiliary cancers, adrenal gland adenocarcinomas, and brain tumors.
They also suffer from severe fibrotic tissue growths called desmoid tumors.
And we cannot forget the physical exam clue. There is a unique ophthalmic finding associated with APC mutations.
Right, congenital hypertrophy of the retinal pigment epithelium, or CHRPE.
If an ophthalmologist looks into the eye and sees these flat, darkly pigmented bear track lesions on the retina, it is often completely asymptomatic for the patient. But it serves as a massive diagnostic red flag for an underlying APC mutation.
Okay, so that is the explosive presentation of classic FAP. But the APC gene is massive, and mutations don't always destroy the gene entirely.
Which leads us to a milder variant called attenuated FAP, or AFAP.
Yes.
And here is where it gets really interesting for the molecular biologists listening. How does a mutation on the exact same APC gene result in thousands of polyps in cancer at age 35 in one patient, but maybe only 40 polyps in cancer at age 60 in another?
It is all about the location of the mutation on the gene.
Location, location, location.
Exactly. In classic FAP, the mutations usually occur in the center of the gene, resulting in a highly truncated, completely useless APC protein. The one pathway break is totally destroyed.
But in attenuated FAP,
In attenuated FAP, the mutations tend to occur at the extreme ends of the gene, either the very far 5' end or the 3' end. These specific mutations might allow for the production of a partially functional protein. It might bind beta-catenin weakly, or only some of the time.
so the brake pedal is faulty and slipping, but it's not completely gone.
Right, and this leads to a much slower, less explosive accumulation of polyps.
And there is one very specific mutation in AFOP that you must know from an epidemiological standpoint, the APC I3307K mutation.
Yes, the APC C.3920TA, or PGI1307K mutation. This is a classic founder mutation, most commonly found in individuals of Ashkenazi Jewish descent.
The statistics from the sources here are striking and highly relevant for genetic counseling.
Very much so.
Among Ashkenazi Jewish individuals in the United States, this specific mutation is found in 11.5% of individuals presenting with CRC, compared to only 7.2% of those without CRC.
And carrying this mutation confers an approximate 70% lifetime risk of developing colorectal cancer.
But again, the clinical presentation is wildly different from classic FAP. Instead of thousands of polyps, AFAP is usually diagnosed when a patient has fewer than 100 adenomas.
Sometimes it's just 20 or 30.
And the timeline shifts drastically to the right. The median age for a CRC diagnosis in AFAP is between 55 and 58.
Which is 10 to 20 years later than in classic FAP.
Although vigilance is key, because cases have been reported in individuals as young as 29 and as old as 81.
True. But because the polyp burden is much lower and the onset is later, regular aggressive colonoscopy and polypectomy can often successfully delay or completely eliminate the need for a prophylactic colectomy in these patients.
The literature also notes they may benefit from aspirin chemoprophylaxis to slow polyp growth.
Good point.
And we shouldn't forget that this mutation isn't exclusively a risk for the colon, and it isn't exclusively found in the Ashkenazi Jewish population either.
No, it's not.
The epidemiological data specifically states that non-Jewish white individuals carrying the APC I307K mutation face increased risks for a whole different set of cancers, including melanoma, stomach, liver, thyroid, breast, and prostate cancer.
It just shows how the exact same genetic defect can interact with different broader genetic backgrounds to produce totally different phenotypes.
Absolutely. Now, just like Lynch syndrome had Muir-Torre and Turco as subtypes, APC mutations also have highly specific name syndromes based on their extra-intestinal manifestations.
Right. The first is Gardner syndrome.
If I see a board question describing a patient with hundreds of colon polyps, but they also have multiple missing teeth and lumps in their jaw, I'm thinking Gardner.
Gardner syndrome is basically classic FAP plus a very specific set of extracolonic features.
Like what?
You see benign skin lesions like pilomatrixomas and epidermal inclusion cysts. You see bone osteomas, especially the mandible and skull.
And the dental issues.
Yes, dental abnormalities like supernumerary or extra teeth. And you also see the CHRPE eye findings.
But the most terrifying feature of Gardner syndrome from a surgical perspective is the soft tissue manifestation.
Those aggressive desmoid tumors, lipomas, and fibromatosis.
Let's talk about the surgical nightmare of desmoid tumors.
It is a massive clinical challenge. A desmoid tumor is a locally aggressive fibroblastic growth. They don't typically metastasize, but they invade local tissues relentlessly.
Right.
In Gardner syndrome, a surgeon might perform a perfect total colectomy, completely removing the patient's colon cancer risk.
But the surgery itself causes a problem.
Yes, the sheer surgical trauma to the abdomen can actually trigger or exacerbate the explosive growth of desmoid tumors in the mesentery, the tissue supplying blood to the small intestine and the abdominal wall.
And these tumors can wrap around blood vessels and the small bowel, causing ischemia, obstruction, and death even after the colon is gone.
Managing Gardner syndrome isn't just about preventing colon cancer, it's about managing the entire connective tissue system.
And then we have Turcotte syndrome type 2. We discussed type 1 being the recessive Lynch variant with glioblastomas.
Yes.
Turcotte type 2 is autosomal dominant, directly associated with the APC gene. It features the colon polyps, the CHRPE eye findings, spinal cord tumors, and specifically medulloblastomas of the brain.
The contrast between type 1 causing glioblastomas and type 2 causing medulloblastomas is a classic high-yield board exam discriminator.
And to round out the APC variations, we have a very rare, highly specific condition called GAPPS.
Gastric adenocarcinoma and proximal polyposis of the stomach.
This one is fascinating because it totally flips the script on the APC gene. GAPPS is an autosomal dominant condition, but it is caused by germline pathogenic variants located exclusively in the promoter 1B region of the APC gene.
Yes, and the promoter region doesn't code for the protein itself. It acts as the volume knob, regulating how much of the gene is expressed.
Okay.
Mutations specifically in this 1B promoter region lead to a primary phenotype confined almost entirely to the stomach.
So they don't get the classic colon polyps.
Mostly no. These patients develop massive amounts of gastric body fundic gland polyps and have a very high risk of gastric adenocarcinoma rather than the classic colon-heavy FAP presentation.
Although, to be perfectly accurate to the source, large deletions in this promoter region can sometimes spill over and result in a full colonic FAP phenotype.
True.
And there is a bizarre, counterintuitive clinical quirk with GAPPS highlighted in the literature, it actually shows an inverse relationship with Helicobacter pylori infection.
That's just so strange.
Usually in the general population, H. pylori infection is the major driver of gastric inflammation and gastric cancer. But in GIPPS patients, the absence of the bacteria or an inverse relationship is actually noted.
It's a brilliant example of complex microenvironments. It is theorized that the specific altered cellular environment created by the APC promoter mutation might actually be hostile to H. pylori colonization.
Or that the mechanisms driving the fundic gland polyps are just completely independent of the inflammatory cascade normally triggered by the bacteria.
It proves biology rarely follows simple linear rules.
Okay, let's summarize where we are. We've covered the mismatch repair genes, the proofreaders in Lynch. We've covered the APC tumor suppressor gene, the WNT pathway brake pedal in FAP. Now, we are transitioning to a completely different mechanism of DNA maintenance. We are looking at the base excision repair anomaly, which causes MUTYH-associated polyposis, or MAP.
This is a critical transition point for any clinician to understand because we are moving away from the autosomal dominant inheritance patterns we've discussed so far.
MAP is strictly an autosomal recessive inheritance pattern.
Yes, it is caused by biallelic variants, meaning the patient must inherit two mutated copies, one from the mother and one from the father of the MUTYH gene.
The MUTYH gene is the heart of the base excision repair, or BER, system. Let's differentiate this from mismatch repair for a second.
Okay.
If mismatch repair is an editor fixing whole typos or deleted words during the printing process, base excision repair is like a tailor painstakingly snipping out a single chemically damaged thread from a massive tapestry.
That's a great way to put it.
Specifically, NUTYH is designed to fix oxidative damage. When cellular metabolism creates reactive oxygen species, they can oxidize the guanine base in DNA, turning it into 8-oxoguanine.
And this damaged base acts erratically.
Right. During replication, instead of pairing with cytosine like it should, 8-oxoguanine tricks the machinery into pairing it with an adenine. It's a mismatched AG pair.
The MUTYH enzyme's specific job is to scan the DNA, find that incorrect adenine, and snip it out.
But when you have two mutated copies of MUTYH, that tailor is missing.
The oxidative damage becomes permanent, the AG mismatch becomes hardwired into the genome, and mutations accumulate, eventually knocking out tumor suppressor genes like APC.
That biochemical mechanism is elegant, but phenomenologically, looking at the patient in the clinic, MAP is a massive diagnostic challenge.
Because clinically, NAP looks almost exactly like attenuated FAP.
It is classified as an attenuated polyposis syndrome. Patients typically present with anywhere from 10 to a few hundred colonic polyps, with the statistical average hovering right around 50 polyps.
And here is the trap they will set for you on the boards. They will give you a vignette of a 45-year-old patient who comes in for a colonoscopy. You find 40 polyps. The family history is murky. Maybe a grandparent had cancer, but the parents are fine. Your brain immediately thinks fewer than 100 polyps. This is attenuated FAP. I need to test the APC gene.
But you must remember MAP.
Because MAP is recessive, the patient's parents are likely just carriers and completely asymptomatic. It skips a generation, disguising the family history.
Furthermore, the polyps in MAP aren't always just classic adenomas. The histology can be a confusing mix. You will find adenomas, but also hyperplastic polyps, sessile serrated polyps, and mixed hyperplastic adenomatous polyps.
Right. Because MAP mimics AAP so perfectly visually, and because the histology can be mixed, you cannot rely on clinical visuals or basic family history alone.
This clinical ambiguity is the exact reason why modern guidelines mandate the use of broad genetic multi-gene panels. You have to test for APC and MUTYH simultaneously.
You really do. Let's look at the hard statistics for MAP. The average age of CRC onset in an MAP patient is 46 years old. This sits right in the middle. It is generally younger than the onset in AFVP, but slightly older than classic FAP or Lynch syndrome.
And crucially, while it is definitively a polyposis syndrome, CRC can actually develop in some MAP patients without extensive prior polyposis.
Yes, the cancer can arise rapidly from just one or two aggressive lesions.
So as a clinician, what are the strict criteria that should make you suspect MAP and order that multi-gene panel?
You should maintain a high clinical index of suspicion for MAP if a patient meets any of these three criteria.
Okay.
First, they have a lifetime history of at least 10 colorectal adenomas, and they are age 60 or younger.
Right.
Second, they have a lifetime history of at least 20 colorectal adenomas at any age.
And the third.
Or third, they have a lifetime history of at least 20 or more colorectal polyps of mixed histology. This includes adenomas, hyperplastic polyps located proximal to the sigmoid colon, and sessile serrated polyps.
Got it. And just to be thorough on the exam prep, MEP also carries a distinct set of extra-intestinal risks. Malignancies of the small bowel, ovary, and bladder, potentially increased risks for breast and endometrial cancer, alongside benign conditions like thyroid nodules, jawbone cysts, and our old friend from the APC section, CHRPE.
Right.
Okay, let's keep moving. We've looked at the proofreaders in Lynch, we've looked at the single base excision tailors in MAP. Now let's zoom in on the actual molecular machinery doing the heavy lifting.
The enzymes physically synthesizing the DNA strand itself.
Exactly. This brings us to polymerase proofreading associated polyposis, or PPAP, involving the PLA and PeopleD1 genes.
This is a relatively newer, incredibly deep area of molecular oncology.
During DNA replication, the actual construction of the new DNA strands is handled by polymerase enzymes.
Right. The PulpA-L gene encodes the catalytic subunit of DNA polymerase epsilon, which synthesizes the leading strand.
And the PLD1 gene encodes polymerase delta, which synthesizes the lagging strand.
But these enzymes are brilliant. They have their own built-in exonuclease proofreading function.
Right.
They check their own work in real time as they build the strand.
So if they add the wrong letter, they hit the brakes, reverse, cut it out, and fix it.
But when there is a mutation, specifically in the exonuclease domain of KL or PLD1, that internal checking system is destroyed.
The enzyme just builds and builds, completely blind to the errors it's making.
The error rate during DNA replication absolutely skyrockets.
Now, the literature notes that mutations in the poly gene are most frequently somatic, acquired only within the tumor itself.
However, when a PLO mutation does occur de novo in a patient's germline, they now have a hereditary syndrome, and they have a 50% chance of passing that devastating mutation onto their children via autosomal dominant inheritance.
And uniquely, from a pathology standpoint, CRCs associated with this polymerase proofreading failure are always MSIS, or microsatellite stable.
Let's pause on that, because that is totally counterintuitive.
Right. If the primary DNA builder is making millions of mistakes, why is the tumor microsatellite stable? Shouldn't it be highly unstable like in Lynch syndrome?
It's a brilliant question. It comes down to the specific type of errors being made.
Okay, explain.
Mismatch repair defects in Lynch syndrome cause massive problems in repetitive DNA sequences, microsatellites, causing them to expand or contract chaotically.
Right.
Polymerase exonuclease defects, however, cause ultra-high rates of single-base substitutions, port mutations scattered randomly throughout the entire genome, but they generally leave the lengths of the microsatellite repeats intact.
So the tumor is hypermutated, but technically microsatellite stable.
Yes, that is a phenomenal distinction for the PhD researchers listening.
Let's look at the statistics for the PALA mutation because they are incredibly heavy.
Based on a major study involving 47 carriers across 20 different families, palea carriers presented with an average of 19 colonic adenomas, with a range stretching from just 1 to 68.
Over 81% of carriers had at least 2 adenomas. But here is the terrifying statistic. Despite the relatively low polyp count, the CRC risk is profound.
63.8% of these carriers were diagnosed with colorectal cancer.
And the average age at first diagnosis was 40.7 years old.
That is astoundingly young for a syndrome that only produces an average of 19 polyps.
It highlights how rapidly these specific polyps progress from benign adenoma to invasive malignancy because the mutation rate is so incredibly high.
And the risks don't stop at the colon. Half of the carriers, 50%, develop duodenal adenomas.
Furthermore, 6.4% of carriers were diagnosed with primary brain tumors at a staggeringly young average age of 30.6.
Because of these diverse presentations, the clinical criteria to suspect a PLA mutation often overlap with other attenuated syndromes.
You should suspect it if you see 20 to 100 adenomas.
Or if the family meets the Amsterdam criteria for CRC.
Or if the patient presents with CRC and 5 to 20 adenomas diagnosed before age 50.
And then we have its sister gene, PLD1, which encodes polymerase delta. The statistics here are even more intense.
A study of 22 carriers showed an average of just 12.3 adenomas. Yet, colorectal cancer was diagnosed at an incredibly young average age of 35.9.
Let that sink in for a moment. An average age of roughly 36 years old for a colorectal cancer diagnosis, with barely a dozen polyps present in the entire colon.
This requires immense proactive clinical vigilance. If you wait for a massive polyposis phenotype to develop, you will lose the patient.
But the absolute key differentiator for PLD1, the giant red clinical flag that separates it from POL on a board exam vignette, is the massive concurrent risk for endometrial cancer.
Exactly. Endometrial cancer was identified in 57.1% of female PLD1 carriers at a mean age of 51.4.
Because of this dual threat to both the colon and the uterus, the Amsterdam's second criteria, which specifically includes endometrial cancer alongside CRC in its family history calculations, applies strongly here.
So, if you are sitting for the FRCS and the vignette describes a family history with very early CRC and high rates of endometrial cancer, your first thought is Lynch.
But then the prompt tells you the tumors are MMR intact and microsatellite stable.
The diagnosis isn't Lynch, it is POLD1. It's like finding the exact fingerprint of the broken machinery in the cell.
Okay, we are shifting gears entirely. Up until now, we've been talking almost exclusively about adenomatous and serrated polyps lesions driven by WNT pathway or DNA repair failures.
Now we are transitioning to the hamartomatous syndromes. These are driven by entirely distinct molecular signaling pathways and produce a very different type of histological polyp.
This is an important histological distinction. An adenoma is a dysplastic precancerous overgrowth of epithelial cells.
But a hamartoma.
A hamartoma, on the other hand, is a disorganized, tumor-like overgrowth of native, mature cells and tissues that normally belong in that location.
They're often heavily vascularized and contain abundant stroma.
While hamartomas themselves are technically benign, the genetic syndromes that cause them create a microenvironment highly susceptible to malignant transformation.
Let's start with the most prominent one, juvenile polyposis coli. And to clarify right off the bat, juvenile in this context refers entirely to the histological type of the polyp.
A specific hamartoma characterized by dilated, mucus-filled glands and an inflammatory stroma.
Right. It does not necessarily refer to the age of the patient, although clinical screening for these patients does often begin in childhood.
Exactly. Juvenile polyposis syndrome results from germline mutations in one of two specific genes, either the BMPR1A gene or the SMAD4 gene.
It follows an autosomal dominant inheritance pattern, though it is vital to note that a significant portion of these mutations occur de novo, meaning there may be no family history whatsoever.
The primary phenotype is the development of multiple gastrointestinal hamartomatous polyps, ranging from a few to hundreds, carrying a significantly increased risk of gastric, small bowel, and colorectal cancers.
The median age of onset for CRC in the syndrome is 36, and for gastric cancer, it is 41.
Again, incredibly young ages that demand early, aggressive endoscopic surveillance.
But I want to focus deeply on the genetic split here. The source material draws a very sharp, highly tested distinction between the BMPR1A mutations and the SMAD4 mutations.
If we connect this to the bigger picture of molecular signaling, SMAD4 is a central critical node in the TGF-beta signaling pathway.
TGF-beta transforming growth factor beta.
Right. It's a master cytokine pathway that controls cell growth, differentiation, and apoptosis. It usually acts as a tumor suppressor in healthy epithelial cells.
When TGF-beta binds to a cell receptor, it activates SMAD proteins, which travel to the nucleus and regulate gene expression.
And SMAD4 is the common co-mediator. All the other SMAD proteins have to bind to SMAD4 to get into the nucleus.
So when the pathogenic variant is specifically in the SMAD4 gene, the entire TGF-beta pathway is crippled, and the clinical manifestation is significantly more severe.
How does that severity manifest clinically compared to BMPR1A?
While patients with SMAD4 mutations have a much higher frequency of massive, severe gastric polyposis and overall gastrointestinal cancers compared to those with BMPR1A mutations.
But crucially, the SMAD4 mutation crosses over into severe, life-threatening extraintestinal vascular issues.
Because TGF-beta is also essential for blood vessel development, these patients are at high risk for hereditary hemorrhagic telangiectasia, or HHT.
This condition causes malformed, fragile blood vessels, arteriovenous malformations.
They are also at risk for mitral valve disease and, terrifyingly, severe aortic root dilatation, which can result in spontaneous, fatal aortic aneurysms or dissection.
Let's translate that into a board scenario. An FRCS candidate needs to know that if a 30-year-old patient presents with colonic juvenile polyps, And they casually mention they suffer from severe recurring epistaxis and nosebleeds caused by HHD telangiectasias in the nasal mucosa, or if an echocardiogram shows an enlarged aortic root, that patient almost certainly has a SMAD4 mutation, not BMPR1A.
You are managing a cardiovascular time bomb alongside the cancer risk.
Precisely. The genetic distinction completely alters the clinical management. Next, in the hamartomatous category, is Peutz-Jeghers syndrome.
This is caused by mutations in the STK11 gene, which acts as a tumor suppressor regulating cell polarity and metabolism.
This is an autosomal dominant disorder, but uniquely among many of the syndromes we've discussed, it has universal penetrance.
Universal penetrance, meaning if you inherit the STK11 mutation and you live long enough, you will express the clinical phenotype. There are no silent carriers.
About half of patients inherit it from a parent, and about half are de novo mutations.
Peutz-Jeghers is famous for two major things. First, the development of massive hamartomatous polyps throughout the GI tract.
But unlike FAP or MAP, which cluster in the colon, Peutz-Jeghers polyps have the highest frequency and size in the small bowel, specifically the duodenum and proximal jejunum.
These aren't just long-term cancer risks. They cause immediate severe mechanical problems in childhood or young adulthood.
They bleed, causing chronic anemia. They grow massive and cause bowel obstructions.
And most dangerously, they act as lead points for intussusception, where the bowel physically telescopes in on itself, causing ischemia and necrosis.
And because these massive polyps are primarily located in the deep small bowel, standard upper endoscopies and colonoscopies will completely miss them.
The diagnostic and management protocols mandate the use of small bowel capsule endoscopy or double balloon enteroscopy.
The latter is crucial because it actually allows the endoscopist to perform therapeutic polypectomy deep in the jejunum, removing these massive hematomas to prevent those mechanical disasters without subjecting the patient to open laparotomies.
And the second famous feature of Peutz-Jeghers is the pathognomonic physical sign. If a patient walks into your clinic, you might literally spot the diagnosis before they even introduce themselves.
You were referring to the mucocutaneous pigmentations.
Yes.
These are flat, dark, melanin-pigmented macules, measuring 1 to 5 millimeters. They look like dark freckles, but they appear in very specific, highly unusual locations, typically clustered densely on the lips, the inner oral mucosa, and the fingertips.
The formal diagnostic criteria for Peutz-Jeghers actually require the presence of these characteristic pigmentations alongside the typical endoscopic findings of small bowel hamartomas or a confirmed family history.
And beyond the GI tract, Peutz-Jeghers carries an aggressively elevated risk for a wide spectrum of malignancies: colorectal, gastric, and small bowel cancers.
But importantly, there is a massive risk for breast cancer and pancreatic cancer. The oncological risk curve goes nearly vertical after age 50.
Because of the sheer lethality of pancreatic adenocarcinoma, adults identified with STK11 mutations require dedicated, high-resolution screening of the pancreas using endoscopic ultrasound or an MRM-RCP protocol.
The final hamartomatous syndrome we need to cover is Cowden syndrome. This falls under the much broader diagnostic umbrella of PTN hamartoma tumor syndrome, or PHTS.
As the name explicitly states, this is caused by germline mutations in the PTN gene.
Okay, let's unpack PTN, because the clinical presentation is a wild ride. The literature states that individuals with PTN mutations develop various colorectal polyps, and it's not just one type.
They get a chaotic mix of hamartomas, adenomas, ganglionomas, serrated polyps, juvenile polyps, and lymphoid aggregates. They face a 2 to 3-fold increased lifetime risk of colorectal cancer.
But the extraintestinal manifestations are staggering. They face massively increased risks of breast cancer, thyroid cancer, specifically follicular renal cell carcinoma, and endometrial cancers, plus melanoma.
And then you have the benign conditions: macrocephaly, a physically enlarged head circumference, Hashimoto's thyroiditis, complex vascular malformations, neurodevelopmental disorders like autism spectrum disorder, and severe immune deficiencies.
So I have to ask the deep molecular question, what does this all mean? How does a single genetic mutation cause colon polyps while simultaneously increasing the physical size of the brain, causing neurodevelopmental disorders like autism, and wrecking the immune system? How does one protein do all of that?
This is where we see the absolute brilliance and fragility of molecular biology. It highlights PTN's role as a master regulator.
PTN stands for phosphatase and tensin homolog.
It is arguably one of the most important tumor suppressor genes in the entire human genome. It acts as the primary systemic brake pedal for the PI3-KDSH-tempor signaling pathway.
That specific biochemical pathway controls fundamental cellular processes across virtually every tissue type in the body. It controls cell division, cell survival, cell size, and metabolism.
So when PTEN is mutated, the brake pedal is ripped out of the car. The LTR pathway is permanently floored.
And let's look at how that unchecked pathway manifests in different tissues. In the developing brain of a fetus, without that PTEN brake, neural cells grow physically larger and divide more than they should.
This leads directly to macrocephaly, and the altered, overly dense neural networking presents behaviorally as autism.
In the immune system, uncontrolled cell survival means autoreactive immune cells that should undergo apoptosis instead survive and attack the body, leading to immunological dysregulation and autoimmunity like Hashimoto's.
And in the glandular and epithelial tissues, the breast, thyroid, kidneys, and the mucosal lining of the GI tract, that unregulated growth leads first to disorganized hamartomas and eventually, as more mutations accumulate, to frank malignancies.
PDN doesn't just do one specific thing, it regulates the fundamental baseline rate of growth for the entire biological system.
That is profound. It really puts the sheer complexity of targeted oncology into perspective. You aren't just treating a colon polyp, you are managing a total systemic dysregulation of cell size and survival.
All right, we are entering the final major block of our deep dive. We are moving away from the clearly defined single-gene CRC syndromes where we can easily sequence a blood draw and find the culprit.
We are now going to explore non-genetic criteria and syndromes where CRC is a secondary yet vital threat.
Let's start with a condition defined entirely by clinical counting rather than genetic sequencing: sessile serrated polyposis syndrome.
Previously known in the older literature as hyperplastic polyposis syndrome, this is actually currently the most common colorectal polyposis syndrome encountered in clinical practice.
It is characterized by the widespread accumulation of serrated polyps, which include hyperplastic polyps, sessile serrated lesions, and traditional serrated adenomas, often alongside conventional adenomas.
But the defining frustrating feature here is that despite evidence of a strong family history, consistent with autosomal recessive inheritance in some specific cohorts, no single specific genetic abnormality has been definitively identified yet.
That is the crux of the issue. There is no PTNN, no APC, no MUTYH to test for. You can't draw blood, run a panel, and sequence the diagnosis.
The diagnosis is entirely clinical, based firmly on the strict World Health Organization 2019 criteria. You literally have to count and measure the polyps meticulously over the patient's entire lifetime.
The WHO 2019 criteria dictate that a patient meets the diagnosis for sessile serrated polyposis syndrome if they fulfill one of two specific conditions.
Condition 1. The presence of at least 5 serrated polyps located proximal to the rectum, all measuring at least 5 millimeters in size, with the crucial caveat that at least 2 of those polyps must measure 10 millimeters or larger.
So to translate that to the endoscopy suite, you find 5 decent-sized serrated polyps high up in the right or transverse colon, and 2 of them are quite large, over a centimeter. That triggers the diagnosis.
Right. Condition 2 is based simply on sheer volume. 20 or more serrated polyps of any size scattered throughout the entire colon, with the stipulation that at least 5 of them must be located proximal to the rectum.
If a patient meets either of those thresholds over the course of one or multiple colonoscopies, they have the syndrome, regardless of what their genetic panel says.
And because we don't have a specific genetic marker to guide us, the surveillance loops are intense and highly burdensome for both the patient and the system.
If a patient has a first-degree relative diagnosed with this syndrome, their baseline screening colonoscopy needs to start early, specifically at age 40, or at the age the youngest affected relative was diagnosed, or 10 years before the earliest CRC diagnosis in the family, whichever comes first.
Once a patient is officially diagnosed, the surveillance is relentless. If you do a follow-up colonoscopy and clear the colon and no polyps are found, you still must rescope them every 5 years.
But if proximal serrated polyps or multiple adenomas are found during a check, the loop tightens drastically to every 1 to 3 years.
It is a high-maintenance clinical scenario requiring strict, unwavering adherence to endoscopy schedules. Because these serrated lesions can harbor rapid progression pathways to CRC, missing a 3-year interval could mean missing a curable lesion.
Next on our list of syndromes where CRC is a prominent threat is the most infamous, devastating tumor suppressor failure of them all: Li-Fraumeni syndrome.
Li-Fraumeni is caused by germline mutations in the TP53 gene. If PTN is the master brake pedal for cell growth, TP53, which is often universally referred to as the guardian of the genome, is the master self-destruct button for any cell with catastrophic DNA damage.
Normally, if a cell is exposed to radiation or toxins and its DNA is severely fractured, TP53 activates. It pauses the cell cycle to allow for repairs.
If the damage is too severe to fix, TP53 triggers apoptosis-programmed cell death. It forces the damaged cell to kill itself to protect the rest of the body.
When TP53 is mutated in the germline, that self-destruct mechanism fails. Cells with catastrophic cancer-causing genetic damage simply ignore the errors, continue to divide, and rapidly form aggressive tumors.
The cancer risks in Li-Fraumeni are almost hard to read. It is an incredibly heavy diagnosis. Patients face a 50% risk of developing some form of cancer by age 40 and an 80 to 90% risk by age 60.
And these aren't just one type of cancer, they blanket the entire body. Female patients face nearly a 100% lifetime risk of early-onset breast cancer.
Patients develop pancreatic ductal adenocarcinoma, soft tissue and bone sarcomas, aggressive brain tumors, leukemias, and adrenocortical carcinomas.
And amidst that horrific multi-system landscape of cancer risk, colorectal cancer remains a highly significant threat.
The median age of CRC onset in a Li-Fraumeni patient is astoundingly early, between 33 and 38 years old.
The literature strongly recommends that dedicated colonoscopic screening begins in these young adults as soon as their statistically estimated CRC risk exceeds 0.6%, often starting in their early 20s.
It's a syndrome that requires an entire dedicated team of oncologists managing whole-body MRI surveillance across every major organ system annually.
Now let's circle back to the exact scenario we opened the show with, a disease that most clinicians associate strictly with pulmonology and gastroenterology, but has a massive, hidden, hardwired colorectal cancer risk: cystic fibrosis.
Cystic fibrosis is a recessive genetic disorder caused by biallelic mutations in the CFTR gene, which essentially regulates chloride and fluid transport across epithelial cell membranes.
Historically, the clinical focus has always been entirely on the thick, viscous mucus destroying the lungs and the pancreatic duct insufficiency causing malnutrition.
But what is becoming increasingly vital for modern oncologists to understand is the GI oncological risk.
The data highlights that patients with cystic fibrosis have a 5-fold increased baseline risk of developing colorectal cancer compared to the general population. Even CF carriers, people with just one mutated CFTR allele, have a small but statistically significant increased risk.
But here is the startling statistic we mentioned at the start. The risk doesn't stay at 5-fold.
For patients with severe CFTR genotypes who undergo a solid organ transplant, most commonly a bilateral lung transplant to save their lives, that CRC risk rockets to a staggering 20-fold increase.
What's fascinating here is the intersection of genetics, local tissue microenvironments, and modern medical interventions. The CFTR mutation directly alters the cellular environment of the colon.
The altered mucus and ion transport likely causes chronic, low-grade inflammation, altered cellular turnover, and changes to the microbiome, raising that baseline CRC risk to 5-fold.
But when a patient gets a lung transplant, they are immediately placed on heavy, lifelong systemic immunosuppressive therapy to prevent their body from rejecting the new lungs.
And the immune system's secondary job, its natural ability to hunt down and destroy early microscopic cancer cells in the colon before they form a mass, is completely suppressed.
Exactly. You combine a genetically primed, chronically inflamed colon with a silenced immune surveillance system, and the cancer risk multiplies exponentially up to that 20-fold figure.
Furthermore, there are well-recognized dramatically increased risks of esophageal, small bowel, hepatobiliary, and pancreatic cancers in this post-transplant CF population. They survive the lung failure only to face an onslaught of GI malignancies.
We're going to come back to the philosophical weight of that idea in a moment. But first, let's just briefly touch on the final category mentioned in the literature, the moderate penetrance genes.
These are genes that don't guarantee a massive explosive syndrome like FAP, but they firmly tip the statistical scales.
The current literature highlights two in particular that are showing up more frequently on multi-gene panels. The first is CHE2.
This is a tumor suppressor gene that interacts dynamically with the mismatch repair pathway and has been linked with certain Li-Fraumeni-like phenotypes.
Pathogenic mutations here only minimally increase the specific risk of CRC. However, finding a CHE2 mutation is critical because it significantly raises the risk for breast and prostate cancers, brain tumors, and sarcomas. It alters the screening protocol for the rest of the body.
And the second is ATM, a gene deeply involved in detecting DNA double-strand breaks and initiating repair.
Mutations in ATM are commonly observed in CRC, especially in patients who also have concurrent Lynch syndrome.
The text notes that promoter hypermethylation of the ATM gene, a silencing mechanism similar to what we discussed with APC and MSH2, is found in up to 40% of all CRCs and adenomas. Germline mutations in ATM also carry an increased risk of stomach, lung, and notably breast cancers.
These moderate penetrance genes truly represent the expanding frontier of molecular oncology. As massive multi-gene panels become cheaper, faster, and much more comprehensive, we are finding more and more of these subtle genetic influencers.
They require highly nuanced, individualized clinical management and heightened surveillance rather than the aggressive prophylactic organ removals we see in the high-penetrance syndromes.
And with that, we have successfully traversed the entire landscape laid out in our source material.
We've moved from the proofreading failures of the mismatch repair genes in Lynch syndrome to the massive structural brake pedal defects in the APC gene with classic and attenuated FAP.
We decoded the base excision, Taylor, failing in MAP, and the polymerase proofreading errors driving hypermutation in POL-A and POL-AD1.
We explored the distinct systemic hamartomatous pathways of PTN, STK11, and SM84, and finally, the broader systemic failures like TP53 and the incredibly complex reality of cystic fibrosis.
It proves, fundamentally, that colorectal cancer isn't just one disease. It is a massive, diverse spectrum of highly specific molecular failures, each requiring a completely tailored approach to diagnosis, surveillance interval, and surgical intervention.
For you listening, the FRCS candidate staring down a board vignette, or the PhD researcher mapping out a new signaling cascade, understanding these precise distinctions is your ultimate goal.
Knowing that a 36-year-old with CRC might have PLD1 if there's endometrial cancer in the family tree, or they might have juvenile polyposis if they also present with an aortic root dilatation. Or they might have a PEEL mutation if the tumor is mysteriously microsatellite stable, despite a high mutation burden.
These specific median ages, the interacting gene targets, and the exact polyp counts are exactly what separate competent practitioners from true, life-saving experts in the field.
But before we finish, I want to circle back to the hook of our discussion. I want to look at cystic fibrosis again, because it raises a massive biological question extrapolated directly from the epidemiological data we just reviewed.
The 20-fold CRC risk after a lung transplant.
Yes. For decades, cystic fibrosis was viewed almost exclusively as a pediatric respiratory and nutritional disease because, tragically, patients rarely survive long enough for other systemic, slower developing issues to manifest.
But as medical science advances brilliantly, as bilateral lung transplants and revolutionary CFTR modulator drugs keep these patients alive and thriving for decades longer, we are inadvertently uncovering dormant genetic time bombs, like this massive colorectal cancer risk.
The CFTR mutation was always an oncogenic risk for the colon. The patients just never lived long enough to show it.
It's a chilling, humbling thought. We fix the immediate fatal threat only to lift the veil and reveal a second, hardwired genetic danger lurking underneath.
Exactly. And it forces us to ask a much larger, almost philosophical question of the entire human genetic landscape.
As we continue to develop cures or profound management strategies for other severe, life-limiting genetic diseases, what other aggressive, genetically hardwired cancers are waiting in the wings?
What other complex oncological syndromes are currently masked, completely invisible to us, simply because those patients haven't historically lived long enough to develop them?
It is a question that guarantees the field of molecular oncology will never truly be settled. The diagnostic waters will always hold new, undiscovered depths. Thank you for diving in with us.